So in case control studies, we cannot calculate risk or incidence, and that is because we're starting with the diseased individuals and we're looking backwards in time for their exposure to a risk factor of interest. And therefore, we cannot calculate relative risk as we do in a cohort study. Instead, we calculate the odds ratio, which I introduced in a past lecture, and this is based on the concept of relative odds of disease. And it's illustrated here in a basic sense in that the odds of case exposure is the proportion of cases exposed divided by the proportion of cases not exposed, and the similar pattern for the odds in the control exposure. So we set up our 2x2 table just as we have in the past with our prior studies, where we have the exposures along the rows and the outcomes down the columns. But now, because we start with our outcomes and we're looking backwards for our exposure, we're interested in calculating the proportion exposed and the proportions not exposed. So the proportions exposed in the cases would be A over A plus C, and the proportion not exposed in the cases would be C over A plus C. And similarly, for the proportion in the exposed controls and proportions not exposed in the controls are shown here on the right-hand side of our 2x2. So we then would use those proportions of exposure to calculate the odds of case exposure and the odds of control exposure respectively. And with some basic algebra, we can take the ratio of those proportions of exposure and not exposure in our cases and get a ratio of A over C. And similarly, we can calculate the ratio of the exposure and the ratio to the ratio of the non-exposed in our controls, and we get a ratio of B over D. We can then use those two values to calculate the odds ratio, which again is the odds of case exposure divided by the odds of control exposure, which simply put is the cross product of our 2x2 table of A times D divided by B times C. So a simple example shown here is looking at the exposure to smoking among cases defined as people with coronary heart disease compared to a group of controls who do not have coronary heart disease. And upon populating our 2x2 table, we get our results shown here. And the cross product in the numerator would be 112 times 224, and the denominator would be 176 times 88. And that gives us an odds ratio of 1.62. Now, the interpretation of the odds ratio is slightly different than that for the relative risk. Firstly, we can't talk about risk at all when we discuss an odds ratio. We're only able to talk about odds or probability. In this case, we can say that the odds that a patient with coronary heart disease was exposed to smoking is 1.62 times greater than the odds in a patient without CHD or coronary heart disease. Now, the interpretation of the odds ratio estimate is similar to how we interpret the relative risk. And essentially, if the odds ratio is 1 or approximately 1, we conclude that there's no association and we are unable to reject our null hypothesis. However, if the odds ratio is greater than 1, we can conclude that the odds in the exposed is greater than the odds in the non-exposed, and conversely when the odds ratio is less than 1. These can also be flipped to talk about the odds in the diseased is greater than the odds in the not diseased of having been exposed, right? And same down here. One other point to make about the odds ratio is there is interchangeability between exposure and diseased. Now, granted, in a case control study, we start with diseased and we're looking at the odds of exposure, but you could flip the odds ratio interpretation and talk about the odds of disease given exposure. Because there's an interchangeability of the odds ratio, we're allowed to do that. But again, we cannot talk about risk ever when we're talking about an odds ratio. Well, I shouldn't say ever, but because I'm going to talk about an exception to that. But in general, we cannot talk about risk when we're discussing findings from a case control study. Now, another way to look at the odds ratio is shown here. The odds ratio can be viewed as the ratio of the product of the two cells that support our hypothesis, that is, cells A and D, the diseased people exposed and the non-diseased people not exposed, to the product of the two cells that negate our null hypothesis of association, that is cells B and C, corresponding to exposed, not diseased, and not exposed, diseased. Now, I just said that there was an exception to when an odds ratio can provide us with a measure of risk, and I'm going to discuss that now. So a case control odds ratio can be used to estimate a relative risk if only the following conditions are met. And these first two conditions are fundamentally conditions that I think would be germane to any good case control study, and I've discussed these already. It's really this third condition that is important, and that is if the frequency of disease in the population is viewed as small or rare, then we can generally estimate a relative risk given an odds ratio. And I'll go through an example in that shortly. So here is that example. This is for what's considered a rare disease or a condition that occurs at a very low prevalence. And this is a large study of 1,000 people who were included. So among the cases, the number who were exposed was 45, and in the controls, the number exposed was 4,955. So a large difference here in the frequency of cases to controls, as well as the frequency of exposure. So in this case, if we were to calculate the relative risk, we get a value of 1.55, and the odds ratio would be a value of 1.56, showing that these are approximately equal, and that is again because our cases, that is because the prevalence of disease in this particular population is relatively small. Now, in contrast, these are results from a common disease, a disease that occurs at a higher frequency, and here the calculated relative risk is 1.55, but the odds ratio is now 6.52, quite a difference in values here. And notice this relative risk is the same as this relative risk, and that is because I've held constant the proportion of exposure in the cases and the controls for this example. But once again, because of the more frequent disease in this population, the odds ratio and relative risks are rather different. So you may ask then, which value should I use? Well, if it's a case control study, we have to use the odds ratio, because a relative risk is a measure of risk, a measure of ratios of incidence or measures of risk, and theoretically that cannot be assessed or calculated in a case control. Now I want to discuss some problems having to do with the selection of controls, and I'm going to give you an example using coffee and pancreatic cancer. So this is from a case control study of pancreatic cancer, where cases were drawn from 11 different hospitals based on histological confirmation of cancer. And then the controls were selected from the same hospitals, but those controls were admitted for different reasons. But they were admitted by the same physicians as those who admitted the cases. And in this publication, the association was concluded that there was a relationship between coffee drinking and pancreatic cancer. However, that wasn't the main hypothesis of the study, but that's a side note. So here were the results of that study among men in the trial, among men in the case control. And the calculated odds ratio was 2.68. And here was the finding among women of 2.55. So similar odds ratios by gender. Now, the problem with this study was that it had a biased control selection, in that controls were patients who were hospitalized at the same time by the same physician who had hospitalized the cases. And the reason for that was that it was easier to obtain physician cooperation and to identify or find controls for the study. However, the key issue is that most of those physicians were gastroenterologists, and that gastroenterologists were known to be more likely to admit their control patients because they had other GI disorders that necessitated hospitalization. But the other problem with this design that wasn't really understood at the time of the publication was that the patients who were chosen as the controls, i.e. they didn't have the disease of interest, they had other serious disorders associated with their GI tract that led them to be less likely to consume coffee, because coffee was viewed as an irritant for these other GI disorders. So what this did was it led to a selection of controls who were less likely to have the exposure of interest, which then led to an increased measure of association between the coffee consumption and the disease of interest in this study, which essentially was a bias away from the null. This is how the bias worked among the women enrolled in the case control study. The percent of controls reporting coffee in this case control was less than expected, and the percent of controls reporting no coffee was greater than expected. Hence, the controls again weren't representative of the general population. So, in conclusion, this is one example of how a biased control selection can influence your measure of association. And in this instance, the authors falsely concluded that there was a strong association between coffee drinking and pancreatic cancer, when in a sense it was just influenced by too few controls in the study having been coffee drinkers.